You can display the answer, Neeraj.
Can I show the result?
Yeah, so the result.
Okay.
So, uh, hello participants. So we had a very detailed discussion of basics of antibiotic susceptibility test, basics of AST, where M02 was discussed in detail by Pallav sir and Dipasri. So we will continue from there, and we will now focus on the various general terminology and in CLSI, and what are the differences from UCAS. So the question what was discussed with you, what was shown to you is about the various test group or report group of CLSI. The first question what was asked here is which of the following group of antibiotic are not tested in the first day as a primary test panel? Yes. So first day A and B are tested on day one, whereas group C is tested as a supplemental test on day two. Group C is tested as a supplemental test on day two. Group U is the urine specific antibiotic. So this can be tested on day one if it is a urine isolate. Okay, so now you must be wondering what are this ABC group. If you would have focused on first few slides of Pallav sir's session, then you would have realized that these are the report group of CLSR. Even the Pallav sir's session was having this question also. Chlorphenicol for extraintestinal isolate belongs to which group? So it is again a rare situation. So all the rare drug bug combinations will fall under group C.
हाँ, 45 मिनट है.
Can you mute everyone, please? I'm not going able to move. But I'm not. Yeah. So group C are the all these rare drug bug combinations. They belong to group C. So before we go into anything, first we will focus on various report groups. So report groups are nothing but they are the antibiotics what you test in the laboratory are classified into various groups based upon selective reporting strategy. Okay, so this is a CLSI recommendation which is applicable for US based laboratory. So depending on the country specific situations, the antibiotics under each group may vary. So let us see one by one. What is group A? Group A and B include those antibiotics. Suppose you are testing 10 antibiotic for E. coli in your lab. In your test panel has got 10 antibiotics. So those 10 antibiotics can be classified into one of this group. So group A and B are those antibiotics which you test on day one. Group A antibiotics are tested on day one. They are the primary test, and they are reported also to the patient clinical report. Whereas the group B antibiotics are tested on day one. They are also primary test. Primary test means they are tested on day one. However, they are reported only in a selective way. What are the indications where they are reported? I'll be telling in the subsequent slides. Group C are supplemental tests. Supplemental test means they are tested on day two if all group A and B will be resistant. If group A and B drugs all will be found are resistant, then maybe you will be interested to test for like this is more common antibiotic which is applicable in Indian situation is colistin testing for Enterobacteriaceae family. Okay, so they are supplemental tests. There are some other examples, other indications to include under supplemental. I will tell you in the subsequent slide. Group U are the additional, the specific antibiotics which are tested only for urine isolates. The classical example is nitrofurantoin. And of course, group INV is the investigational antibiotics which is not approved by US FDA yet. However, they are under the process of approving. Okay. Group O include others. Those antibiotics in CLSI, they have named them as O or other group which have a clinical indication. However, they are not routinely tested or reported in US based lab. So this particular classification is CLSA has made for US based laboratory. So we may find it a little difficult to understand because our way of classification is slightly different, which I will be telling you subsequently. So so group A, you all know that group A, as I told you, they are tested on day one and they are reported to the patient. That's all. So group A are all are tested and reported. Group B are those who are tested. These drugs are tested on day one, but reported only in selected situation, and the most common indication if the group A agents are found to be resistant. This is the first and the most important indications. Other than that, there are other indications like reported in selected specimen source. For example, in US based lab, third generation cephalosporin, they report for enterobacteriaceae only for CSF specimen. This example will not be applicable for Indian situation because Indian situation third generation cephalosporin we test otherwise also for any clinical isolate of, I mean, any specimen source of E. coli, enterobacterial. But in US based lab they do like that. So the, I mean, the concept here is if you report any selected specimen source, of course, other than urinary antibiotic, urinary antibiotic are classified under U. Other than that, if your lab is testing for sputum or for blood, any particular antibiotic, then you can class them under group B. Okay, for selected specimen source testing. Okay, cases of patient allergy, intoleration, etc. to group A agent. If group A agent are resistant, of course, is one indication. Group A agent, if the patient is having allergy or intolerations, or it is sensitive but the treatment failure is noticed by the clinicians, then all those cases you can report group B agents also, because group B agent would have been tested on day one. Polymicrobial infection. Polymicrobial infection is another indication where you have to release the group B agent. Suppose I will give you an example. Ceftriaxone, suppose is your group A, meropenem is your group B agent, and the organism is susceptible to both. You have found one E. coli from urine which is susceptible to both ceftriaxone and meropenem. So as a result, what you are supposed to do is you will be releasing only the group A agent, that is ceftriaxone result. You will not release the meropenem result. However, you have a polymicrobial infection. You have another organism grown in urine or maybe in any other specimen, polymicrobial infection, and if Klebsiella is also there, which is resistant to ceftriaxone and sensitive to meropenem, in such case, it is advisable. I repeat, it is advisable to release the meropenem result of E. coli also, because you have to give a double coverage for Klebsiella as well as the meropenem. So the clinicians will be interested to know whether the meropenem is also active for E. coli or not. So this is an example. You have polymicrobial infection. Then infection involving multiple site, like the same example we can tell. If your second the first organism is E. coli, from urine. If the second organism is Klebsiella from another side, suppose blood, then if this isolate has a different pattern of AST, then you may have to consider of releasing a common antibiotic report. In such case, maybe the group B result has to be released. And of course, for the infection control purposes, if your infection prevent if your infection control team wants to see the result of specific antibiotic, again you have to release them. Then group C. Group C are not tested on day one. By definition, they are not tested on day one. They are secondary panel antibiotic. They are tested only when your both A and B bugs are drugs are found to be resistant. Okay, like if there is a known endemic epidemic strain resistant to several of the primary drug, then you may have to release the group C result. In US, group C may be a big thing. In India, group C is kind of a primary test what we do, because our strains are so much exhibiting resistant that
Exactly.
we are forced to test even group C on
Sir,
day.
in NICU settings, excuse me, sir. Sir, in NICU settings, when we are already dealing with multi-drug resistant bugs,
Yeah, this
and the
classification is
clinician,
not applicable.
sorry, sir.
This classification of ABC may not be applicable in your
Exactly.
NICU setting, where you will have multiple MDR organisms. Then this
And the
class.
clinicians are very in a hurry to start off. So
Yes.
that is the time we can
Yeah,
directly
that
go
is
to.
why what I'm doing now is I'm just explaining the CLSI concept. At the same time, I'm also emphasizing that this ABC group classification, the so-called classification of CLSI, may not be applicable in Indian setting. Okay, so when I
Thank
will
you, sir.
present the subsequent slides, it will be more clear, because I will show you what is the modification what we can do for Indian situation, that I'm going to show you in the subsequent slide. So for the treatment of the patient allergic to the primary drug, again the both A and B, if the patient is allergic to A and B drug, you can do. Like if unusual organism, if you have some specific antibiotic, then also you can include under C, and of course any specific antibiotic for the infection control purposes, which are not included in A and B. If A and B included, then it is different. If some antibiotic not included in A and B, but the infection control team wants to see, again you can include them under C. Urine specific antibiotic are very clear. The definition: the nitrofurantoin is a classical antibiotic. Others like certain urinary quinolones like Norflux and trimethoprim, not cotrimoxazole, only trimethoprim, Norflux, fosfomycin, and sulfadoxazole. So these are the urinary specific antibiotic. They should not be reported against any other pathogen from other side. So when you prepare your antibiogram, tomorrow we will discuss about antibiogram. Remember that these are the antibiotics which cannot be included for other site isolate. This has to be included only for urine isolate. Okay, the only exception here is cefazolin, which has a UTI breakpoint as well as a systemic breakpoint, and therefore, especially in the Enterobacteriaceae family, it has a two breakpoint, one UTI breakpoint, one systemic breakpoint, and therefore it is placed in both A and U category. So this is the only exception where it is placed under both the category. There are certain antibiotic which are having a broader uh, indication. Uh, However, for certain pathogen, they are placed under U. I repeat, nitrofurantoin, Norflox, these are the antibiotic what I have described earlier. They are urinary antibiotic for any organism. Whereas these are the two lists. For example, ciprofloxacin. Otherwise, it is a category A antibiotic, but for enterococcus, it is urine specific. Tetracycline again, otherwise it is a category antibiotic, but for Acinetobacter, it is placed under U category. Okay, so this is the list of CLSI list of the gram negative antibiotics for gram negative organism groups in various categories. So it is clear that I mean you can see that there are many antibiotic, but what is not what is C for US, there are many antibiotics we test on day one. For example, Enterobacter C, there are antibiotics such as Aztreonam, ceftazidime, for example, few antibiotics are there which we are forced to test on day one. So this classification may not be applicable for US Indian setting, but yes, the concept is applicable. The concept is applicable. So these are the various CLSI breakpoint organism groups. Based upon the breakpoint, the CLSI gram negative breakpoint, the gram negative organisms have been classified into the six group: Enterobacterial, Pseudomonas aeruginosa, Acinetto, BCC, that is Bacteroides hepacia complex, Stenotrophomonas. So these five groups have five different breakpoints there in CLSI, and rest all gram negatives are classified under other non-enterobacterial group. So before I explain what is other non-enterobacterial group, I want to ask you one question. How you report? How you report in your
Excuse me. Excuse me, Dr. Apurva.
yes?
Can you go to the previous slide?
One second. I'm not
Yeah.
able. Yes.
Why Norflox is not there in urinary for enterobacterials because of resistance?
Yeah, so Norflux is now included in 2021 CLSI. It
Okay.
was not it was removed from the breakpoint group in 2020, 2019 and 20. 2021 CLSI group, again it is appearing in U. So this
Maybe it has again become sensitive.
uh, no, not that is not the reason. Norflux, the reason they have not mentioned, but last couple of edition Norflux they have removed from the CLSI list. So that is why it is not there. But now it should be available because now it is now the breakpoint.
Okay,
Fine.
thank
So can anybody tell how you report what breakpoint you apply for other pseudomonas species in your lab? This CLSI a breakpoint for Pseudomonas aeruginosa. So this is a breakpoint what you report for this antibiotic. Which breakpoint you use for other Pseudomonas species? Anybody can mute, especially
The
any
non-enterobacterial group.
okay, any postgraduate student. Can you unmute yourself and tell what you usually do in your lab? So what we usually do in our lab is we tend to, especially the disk diffusion, we tend to report Pseudomonas species based upon Pseudomonas aeruginosa breakpoint. Are you going to do that? Anybody can
The
tell?
UCAST has some guidelines for other non-fermenters or other
CLSA
not
has, CLSA has a better presentation for other non-enterobacterial. Uh, I wanted to know what we usually do in our lab. Like any of you can who is doing only disk diffusion test, you don't have MIC based test. Can you tell me how you are reporting Pseudomonas species, non-aeruginosa species?
based on Pseudomonas guidelines.
Yes, based upon. So we are forced to do based upon Pseudomonas aeruginosa breakpoint, which is actually wrong. Please remember that Pseudomonas species has to be followed based upon non-enterobacterial breakpoint, and non-enterobacterial breakpoint. If you open CLSI M100, then you will realize that there is no disk diffusion breakpoints are available. Non-enterobacterial breakpoint. So this is a non-enterobacterial breakpoint table. You can see there is no diffusion zone diameters are available. Only it can be interpreted by MIC breakpoint. So what is the meaning of non-enterobacterial group? Of course, it will be discussed in detail under the gram negative coverage. I just want to quickly tell you this group include all other than these agents. You have a breakpoint table for Pseudomonas aeruginosa. You have a breakpoint table for Acinetobacter species. There is a breakpoint table available for CLSA for BCC, that is Burkholderia cepacia complex, and also one breakpoint table available for Stenotrophomonas maltophilia. Other than this four, rest all non-fermenters. Rest all non-fermenters will fall under this. Okay. Aeromonas, Burkholderia, Malai, Pseudomalai, and Vibrio. This also will be excluded from this table because these are explained in CLSI M45. Okay, so basically this include few rare non-fermenters what we may encounter in our lab. Detail of this will be discussed under gram negative. Okay, then this is the ABCU classification of your gram positive organisms. So this is been taken from CLSI. Okay, what we can do in Indian situation? Indian situation, we can have a modified version of ABC classification. So A and B, the concept is same. A and B are has to be tested on day one, and A can be reported on day one, whereas B group of drug can be selectively reported if a resistance is exhibited to A group of drug. For example, these are the common antibiotic. We usually test gram negative bacilli in blood. If you get a gram negative bacilli in blood, let us assume that you have tested these are the gram negative antibiotic. So among this, the first four antibiotics can be the first line antibiotic. So A group is equal to first line antibiotic, and B group can be called as second line antibiotic. So second line antibiotic can be reported if A group are found to be resistant, and C can be the colistin or any other higher end gram negative antibiotic which can be reserved, which can act as a supplemental test if A and B are found to be resistant. Even this classification also may not apply in most situations. Like for example, in our lab, we test colistin as a primary drug because XDR strains, there is no other option than colistin, so we don't want to delay the treatment. Therefore, we test colistin on day one itself. But in your lab, if you test something on day two, those you can call as group C. And another type of group C antibiotic is based upon identification. Suppose on day one you know it is GNB in blood, and you have used the common GNB antibiotics for susceptibility testing. Day two, the identification you came to know it is Salmonella. So for Salmonella, all these antibiotics what you have tested, you don't report for Salmonella. You only report ceftriaxone and ciprofloxacin for Salmonella. But there are certain additional antibiotics like chlorphenical, azithro, and all. Those you report separately in addition to Salmonella. So those identification specific additional antibiotic which are supplementally tested on day two can also be considered as type of group C antibiotics. And of course, U can be the same definition of E. coli. Those are urine specific antibiotics. So this is all about pub. However, how to decide which antibiotic should go into A, B, C? Again, the guideline here says that you the concept you take from CLSI. However, do not decide to place the antibiotic into A, B, C within by your departmental consensus alone, because microbiology, our department, if you will have a consensus that I will put this antibiotic under A, this B, this C, that is not the case. You have to discuss with your clinical department, because they have to decide. Because in most of the lab, what happens is clinicians will not know why microbiology department is testing so many antibiotics which we don't use clinically. Why microbiology department is uh, not testing some antibiotics what we are using in our in our hospital. So that should not happen. There should be a regular discussion between micro and clinical department. The antibiotic panel what you're going to put should be clinical driven antibiotic panel, not microbiology lab driven antibiotic panel. And of course the antibiotic panel has to be updated yearly without a fail. Okay. And as I told you earlier, in Indian scenario, best is test all on day one and report selectively. This will fit best in our scenario. And I'll tell you one more reason why you should test on all on day one. If you do not test all on day one, you will face a problem when you develop antibiogram, because antibiogram cannot be developed on selectively tested antibiotic. Antibiogram has to be developed only when the antibiotics are tested for all isolate. So for that reason, you should not do selective testing. Okay, so the first part of the session is over. Then we'll discuss general terminology. Can you? Okay, I will show some slides. Then you can show the MCQs. What do you mean by breakpoint? Breakpoint is CLSA clearly says breakpoints are MIC or zone diameters, which will categorize the organism, which will place the organism into various interpretative categories with respect to an antimicrobial agent. So the common interpretative categories are SIR. So the MIC values or the zone diameter values which can categorize the organism into either SIR is called as breakpoint. Okay, these are called as breakpoint. So these are the various interpretative categories SIR. Then other than that you have SDD, also one more interpretative category, and non-susceptible also. So these I will explain you all these categories subsequently. But those MICs or zone diameter which can classify them into this is called as breakpoint. Okay, then MIC or zone diameter value. Then the next question is what is the meaning of AST interpretative categories? The previous slide we have seen that SIR, all these are interpretative categories. The question is how these categories are created, how these breakpoints are created. Remember that the breakpoints are created on based upon these three factors. First is microbiological characteristic. Second is PKPD parameter. PKPD is pharmacokinetic and pharmacodynamic parameter of the antibiotic. And third is clinical outcome data. When you have all three data available, then only you can have clinical breakpoint. So the clinical breakpoint or the SIR, those are terminologies, are based upon those isolates having these three data available with us. Okay, so now I will show you some questions. Can you display the poll questions, please? The poll number 4, can you display, Neeraj?
Yes, sir. I'm showing. I'm displaying.
Uh,
Apurba sir, three of them have raised hands. I think they
I'm
want to
putting it
ask.
starting.
yeah, we can discuss those now.
Okay.
We have
Any-
2.5 minutes.
Okay, 2.5 minutes, yeah, because 5 questions are there. I think 2.5 minutes is not required because now participants are geared up. So, and the questions are simple. My questions are not as complicated as Deepasri's questions. So mine are very simple and straightforward questions. Who has raised hand? They can ask questions if they want, side by side also. Hmm? Yeah.
1.5 minutes left.
1.5 minutes left, it seems. This timer is visible to the participant also.
Yes, sir.
Dr. Sazda, you have raised hand. You have something to speak. We have unmuted you.
Hmm.
30-second left. Time's up.
Okay. So, can you display the answer, please?
Sure.
Okay. So the first question, you all have 88 of you, the 79% of you answered rightly. ECOF is not a clinical breakpoint. ECOF is a epidemiological breakpoint. It is not a clinical breakpoint. Absolutely right. So what do you mean by susceptible and what do you mean by resistant? So those we will discuss now. Susceptible means what? Isolate is inhibited use by usual achievable concentration when the drug is given at the recommended site specific normal or standard dose. I repeat, when you give the normal or standard dose of antibiotic, then it will create it will reach to a achievable concentration in the body which is expected to inhibit the isolate. This is the definition of susceptible. Opposite of that is resistant. That is, isolate is usually not inhibited by the concentration what is achieved when the drug is given at a specific doses. Okay, when you give a specific dose, the standard dose, if you do not achieve the concentration that is going to kill the organism, it is called as resistant. However, there are some other terminology like intermediate and susceptible dose dependent. Okay, so so susceptible dose dependent means very simple, is it will kill in increased dose. It will inhibit or it will kill or inhibit the organism in increased dose. Susceptible means it will inhibit in standard dose. Resistant means it will not inhibit either in increased dose or in standard dose. Intermediate is it may inhibit in increased dose. This is one meaning of intermediate. Okay, we have a question on this also. It may inhibit in increased dose, or it may be a technical error, or the third meaning of intermediate is it may concentrate at specific site and it may inhibit at standard dose. And fourth meaning is it may inhibit in increased dose. However, not enough studies are there to prove this. So can you tell me now the difference between SDD, that is susceptible dose dependent, and intermediate. What is susceptible dose dependent? What is intermediate? I have given you the differences, but still I want to know whether it is clear or not. See,
So in
susceptible.
case of STD, if we increase the dose, there is a guarantee that the drug will work. But
Absolutely,
in
absolutely correct. So in STD, when you increase the dose, there is a guarantee that it will work, because STD, they say that the it is enough clinical trials are there, enough studies are there that increased dose will work. Increased dose will definitely work. That is what is been guaranteed by STD. In intermediate, there are four different meanings. First meaning is it may inhibit in increased dose, but there are no enough study to guarantee. Second meaning is it is maybe a technical error also. It may be a technical error also. The third meaning is the it may be concentrated at specific site, and for that now 2021 CLSI has come up with a symbol called as I caret sign. This sign is called as caret sign. So so this type of symbol is called as I caret symbol. So in CLS, I will show you the subsequent thing. So when this symbol is there, it indicates that it will it will it will act. It can concentrate on urinary site, and in such case it may inhibit the organism even with the standard dose also. Even with a standard dose also. So this is the meaning of this. So so now the third question should be clear. We have all discussed this. So intermediate means clinical trials are not established. If the clinical trials are established to say that increased dose will work, in such are called as SDT breakpoint. In intermediate, the clinical trials are not established. However, increased dose may work, but there is no guarantee. Rest all are correct. The response rate of intermediate strains are lower than the susceptible strain. They show clinical efficacy in the body side where the drugs are physiologically concentrated, and it is a buffer zone to represent a technical error. Okay, so these are the explanation of intermediate. It is a buffer zone. It may represent a buffer zone to represent a technical error. And this is the I caret sign is introduced in 2021, which is there to say that those drugs which are potentially concentrated in urine are given as I caret sign, and in these drugs may work even if you give a standard dose. Okay, so this is the picture you can see. This is the enterobacterial breakpoint table. The enterobacterial, usually the beta-lactam antibiotics and quinolones. These are the two broad category of antibiotics which they have given a I caret symbol here. Both MIC as well as diffusion breakpoint, the I caret symbol is there. The meaning of that is it will work it is physiologically concentrated in urine. Therefore, even it is intermediate, you can safely give the antibiotic to the patient. So these are the list of antibiotic. You can see most beta-lactam antibiotic and most quinolones except few are given as I caret breakpoints are available in CLSI. The third question, if the MIC is in SDD range, it indicates what? Again, here actually till now the technical variation was not a component of SDD. The first three used to be the correct statement. Higher dose SDD means there is a guarantee that increased dose will work, and more frequent dose also will work. More frequent dose will work, increased dose will work, and of course alternate dosing is a type of higher dose, and more frequent dose are a type of alternate dosing. However, the 2021 CLSI, they have introduced a statement saying that a minor component of SGD also may show some technical variation. So that is why the better answer has to be none of the above, edge of 20 or 21. I will show you the statements here. So SGD in 2021 CLSI, if you see, it is given that the susceptibility of an isolate depend upon the doses regimen used for the patient. So higher dose or more frequent dose or both may be needed, and there is a guarantee that it will work. Because if you do a higher dose and more frequent dose, it will result in higher drug exposure to achieve a level which is supposed to kill the organism, supposed to clinically effective against the isolate, and it is literature supported, and it is widely used clinically and approved with sufficient data to justify. And the doses are usually adjusted for the organ function, like those drugs which are having a renal toxicity effect are usually not included for SGD breakpoint, because those are renally safe, are usually included for SGD breakpoint. This is the additional statement what is there in 2021, that it may include a buffer zone for a small technical error, and that is why the answer was changed. Actually the answer was given, we have given the answer earlier as D as the answer, but because the statement is introduced in 2021, therefore we have kept as none of the above as the answer. Next question, SGD breakpoints are available where and all? SGD breakpoints are available in the first three, but it is not available here. So again, most of you have answered this question. So I'll just show you what are the SGD breakpoints available. So there are, in 2021 CLSI, there are three drug bug combinations for which the SGD breakpoints are available. I can explain you here for your better understanding. The classical, I repeat, the most widely used SGD breakpoint at present in the clinical practice is cefepime for enterobacterial. Cefepime for enterobacterial, I repeat, here less than 2 MIC is susceptible, 4 and 8 MICs are resistant, 4 and 8 MICs are resistant, and more than equal to 16 MIC is sorry, 4 and 8 MICs are considered as SGD breakpoint, 4 and 8 MICs are considered as SGD breakpoint, whereas more than 8, that is more than equal to 16 MIC is considered as resistant breakpoint. So if it is susceptible, cefepime, it is found to be susceptible, that is MIC is less than 2, then the dose is a standard dose, 1 gram BD. 1 gram BD is the standard dose. If the MIC is SGD breakpoint, if MIC is 4 SGD, then the dose is either 2 uh, gram BD or 1 gram TDS. This is the dose for SGD 4 MIC. If the MIC is 8, then it is still SGD, but you have to give a higher dose, that is 2 gram TDS. 2 gram TDS. Then if the MIC is 16 or more, then it is considered as resistant. In such case, it is not given. The drug is not given. So this is a clear-cut established breakpoint are available if it is uh, like this. However, for as far as zone diameter is concerned, the zone diameter do not correlate with specific MICs. Therefore, they say that if the zone diameter falls under SGD breakpoint, then the doses has to be the highest SGD dose, that is 2 gram TDS. How for MICs you have a separate dose for 4 and 8 MICs. Like that, zone diameters you do not have separate doses, because zone diameters usually do not correlate with specific MICs. Therefore, if the zone diameter falls to SDD breakpoint, then you give the highest SDD dose, that is 2 gram TDS is the highest SDD dose which can be given. Daptomycin for EPCM is again this is another example where if it is 4 gram 4 microgram denotes that it is SDD breakpoint. In such case, you have to give a increased dose. I repeat here, of course enterococcus will be discussed again in gram positive, but you see here that the daptomycin EPCM has a SDD breakpoint. If ECM doesn't have a susceptible breakpoint, there is no susceptible breakpoint. It has only SDD breakpoint, whereas daptomycin for other enterococcus species, there is a susceptible intermediate resistant breakpoint. Okay, so I repeat. So can you tell me one more antibiotic for which susceptible breakpoint is not available? Anybody can unmute and tell one more antibiotic for which susceptible breakpoints are not available?
Listing.
Yes, colistin. So these are the examples. These are the two examples. One is colistin, where an intermediate only breakpoint is available for colistin, no susceptible breakpoint, as well as daptomycin, where SDB breakpoint is available.
Vancomycin.
There is no susceptible breakpoint. Vancomycin for which organism? Vancomycin has susceptible breakpoint. I don't know.
Daptomycin only for
Daptomycin only if ECM, the SDD breakpoint is there, a susceptible breakpoint is not there. Otherwise, it is there. Okay, next question. Non-susceptible category means what? Uh, why these lines are there? These lines are not going now. Neeraj, why these lines are not going?
You may unshare and try once again the sharing. Please. This will
Answer
be
and
good.
try. Answer and open again.
Yeah.
It got saved. I don't know what. This is a new.
Can I stop sharing result?
No, you can stop sharing this.
Sorry.
Will I share again?
Sir, you close the PPT and once put no, I think it is not going because you have shared your screen only, not the PPT.
Yeah. You may try once again, sir, sharing. It will.
Can I stop sharing result?
Results, yeah, you can stop. All the results are displayed now.
Yeah, all the results are displayed.
Yeah, you can stop sharing.
Okay.
When you show the result, they can close the result by themselves also, no?
Yes, sir.
Okay.
Yeah, because few were telling they are not able to close. Okay, the next question is, what is non-susceptible? Now the PowerPoint is saying, yeah. What is non-susceptible? Non-susceptible means what? There are few drug bug combinations for which only susceptible breakpoints are available. There is no resistant breakpoint available. If no resistant breakpoint available, then that category is considered as non-susceptible if the zone diameter will fall under that values. The classical example here is the classical example available. One example you tell. Anybody can unmute and tell, please.
Penicillin for streptococcus pneumoniae.
penicillin for streptococcus.
Penicillin. Penicillin for Streptococcus pyogenes. What is the breakpoint here? A susceptible breakpoint? Penicillin for Streptococcus pyogenes. Penicillin for Streptococcus pyogenes more than equal to 24 is sensitive and there is no resistant breakpoint available. So that means if you get 25, this is sensitive. If you get 23, for example, what you will report? Anybody can tell if you get 23 what you're going to report?
Resistant.
Non-susceptible.
Cannot report as resistant because resistant
Non-susceptible.
breakpoints are not
Non-susceptible.
resistant breakpoints are not available.
Yeah, yeah.
So what you have to do here is if it is not in the susceptible range, then you have to reconfirm the identification, then repeat the AST by a different method.
Okay.
Repeat the AST by a different method, and if same result is found, if same result that is outside the susceptible range, then you report as NS. NS is non-susceptible category. Non-susceptible category. Non-susceptible category means it is a category where resistant breakpoints are not available. You should not confuse non-susceptible category with not susceptible. Not susceptible means it is I plus R result. Like for example, E. coli, 20% are sensitive, 40% of my isolate are intermediate, and another 40% of my isolates are resistant. That means I can tell that my 80% of my isolates are not susceptible isolates. Not susceptible isolate means they are I plus R equal to not susceptible. So this you should not confuse with non-susceptible. Non-susceptible means the breakpoint is not available. That category is called as non-susceptible. Whereas not susceptible is usually this word is used or to denote I plus R combined percentage if you want to express, that is called as not susceptible. Okay, so these are the various detailed list of CLSI. The PST has nicely piled up this table in our previous workshop time, that the various list of drug bug combinations where resistant breakpoints are not available. Okay, can you open the next poll, please? Can you open the next poll, please, Neeraj?
I'm opening next poll.
Yeah, yes.
All may start polling.
Polling time is 1.5 minutes.
1.5 minutes is the poll time. So
Time's up. Time's up.
Can you display the answer, the explanation, please? Okay, so here the answer is EUCAST. Which category is not there? Can you display the poll result, please?
Yes, I'm displaying the full result.
Okay, so many of you have told ATU. I'm not able to go to the next slide. Which of the following is not an interpretive category according to EUCAST? Okay.
Intermediate.
Intermediate is the answer. It is not area of technical uncertainty. Area of technical uncertainty, it is a interpretative category of EUCAST. There is no intermediate category in EUCAST. EUCAST may I stands for what? The next question is EUCAST may also they use the word I, but I in EUCAST stands for not for intermediate, not for intermediate. Few people have answered. I can see the poll result. It is I for EUCAST stands for susceptible at increased exposure, which is a equivalent category of SD. Equivalent category of SD in CLSI. So CLSI SDD equivalent category is I in EUCAST. I stands for susceptible in increased exposure. Okay. So according to EUCAST, all are true except susceptible in EUCAST means what? So here again a thing what you have to understand here is that isolates that are susceptible in EUCAST, according to EUCAST, S means susceptible means S plus I, because I is susceptible at standard. I mean, the next slide, it is easy to answer. It is easy to understand. In EUCAST, susceptible means the S category means susceptible at standard dose. I category in EUCAST means susceptible at increased dose, which is equivalent of SGD of EUCAST. R is resistant, and ATU is a area of technical uncertainty, which is again due to a technical error. So in CLSI, I category in CLSI means it could be a technical error also, or uh, it could be increased dose may work, which is not very clear. But SDD means in increased dose will definitely work. In EUCAST, I is equal to SDD, that is increased dose will definitely work. They have standardized drug trial to establish this. And ATU is the category what they have used to represent the technical error ambiguity. Okay, so therefore somebody will ask you what is the susceptible percentage. I mean, the susceptible percentage, if you want to analyze, you take both S and I category, because S is susceptible in standard dose, I is susceptible in increased dose. Both together will tell you the susceptible percentage. Same for CLSI also. CLSI, the total susceptible percentage can be calculated as S plus SDD percentage. Correct? So then we'll discuss what is area of technical uncertainty in EUCAST. EUCAST, there is a technical uncertainty terminology. The meaning of this is again a zone diameter, or it is a borderline zone diameter. It is a borderline zone diameter or MIC dilutions which is a technical ambiguity, is not clear that it is actually sensitive or in or resistant. Okay, so it is always considered as technical uncertainty. I will give you one example. This is the enterobacterial breakpoint table of EUCAST. You can see that in piperacillin tazobactam here, 16 the dilution 16 is considered as the MIC dilution 16 is considered as ATU. That meaning of this is what in EUCAST 8 in EUCAST for enterobacterial against piptas 8 or less is considered as sensitive. More than 8, that is 16 or more, is considered as resistant. So a more than 8 is resistant, or which is equivalent to 16 or more. So according to breakpoint table of UCAS, 16 or more is considered as resistant. Out of this, the value 16 is a ATU. The value 16 is a ATU, means if you get 16, then you cannot reliably say that it is always resistant. It may be a technical uncertainty, and the isolate may be actually sensitive also. Okay, so if you follow UCAS, if you get a piptas E. coli, if you get a breakpoint of 8 for piptas E. coli, you can reliably say it is sensitive. If you get a breakpoint of 16, you cannot reliably say as resistant, because it also overlaps with your ATU. It is area of technical uncertainty also. It may be a buffer zone which may say that it is a technical error. So you have to take with a pinch of salt. The clinician has to take the result with a pinch of salt. Similarly, ATU result can happen in the susceptible side also. This is another example of Staphylococcus breakpoint of UCAS. One example I will show you, ceftaroline. Here you can see ceftaroline, a Staphylococcus breakpoint. Less than equal to 1 is considered as a susceptible. More than 2, that is more than equal to 4, can be considered as a resistant. Here you can see MIC of 1 MIC value is a ATU breakpoint. That means if you get MIC 1, although ceftaroline MIC 1 is considered as susceptible according to the breakpoint table, 1 is also a ATU category. So if you get 1, then you cannot reliably say that it is susceptible. It may be a area of technical uncertain. It may be actually resistant also, which you have to rule out. However, zero point 0.5, sorry, however, zero point 0.5 MIC or 0.25, anything lower than that, you can reliably say that it is susceptible. So this is the meaning of ATU in UCAS. UCAS, if you get a ATU breakpoint, then what you have to do? You should take it cautiously. You should inform the clinicians and take it cautiously with a pinch of salt. This is a detailed drug bug combinations according to 2021 UCAS, where ATU breakpoints are available. This classification keep changing every year. The ATU drug bug list is revised by UCAS. So as I told you, if you have ATU breakpoint by UCAS, the following thing can be done. First is you have to repeat the test by yourself to see that if it is a technical error. Next is you can perform any alternate AST method. That is another thing. The third option is you can report the result as ATU instead of reporting R or S. You report as ATU, and you inform the clinician that it is ATU. You have to take with a pinch of salt. The fourth option is you can downgrade you can downgrade the susceptibility report and directly report as resistant, because because it may not work, especially if the ATU is in the susceptible zone size, susceptible range side. If you have a ATU, like how for Staphylococcus aureus I have shown you the example, then in such case you can downgrade the report and you can report as resistant, so that at least the clinician will not use this for the patient. Okay, so this is how the UCAS ATU are there. So now I will show you the next thing, that is epidemiological cutoff. What do you mean by epidemiological cutoff? Epidemiological cutoff means it is a breakpoint where the clinical establishment is not been done. I told you that for any clinical breakpoint, there are three parameters. Parameter one is microbiological data is available. Parameter 2 is PKPD parameters are available, that is pharmacokinetic, pharmacodynamic parameters are available. And third is clinical data also is available, that in vivo data, that is inside the patient it works. All these three data is if all these three data are available, then you can establish the clinical breakpoint. However, in those situations where PKPD data is not available, clinical data is not available, only microbiological data is available, that is the MIC distribution alone is available, then in such case you can only give a epidemiological cutoff breakpoint. You cannot have a clinical breakpoint. So, what do you mean by epidemiological cutoff breakpoint? This is a breakpoint. First of all, it is not a clinical breakpoint. It is a breakpoint which separates the population into the organism population can be separated into wild type and non-wild type strains. Wild type strain means the strains with no phenotypical, no phenotypic mechanism of resistance has been detected. Non-wild type means these are the isolates where phenotypically you are able to detect some mechanism of resistance. So this is how you can divide the microbial population into wild type and non-wild type. And ECOF breakpoints are the breakpoint which can separate the microbial population into wild type and non-wild type breakpoints. Remember that ECOF breakpoints are based upon in vitro MIC data only. There is no clinical data or no PKP data. The second and third component of a clinical breakpoint is missing here. Therefore, ECBs should not be reported as SIR. Wild type equal to S, non-wild type equal to R. This concept is totally wrong. You should not use like this. And ECB should not be used as clinical breakpoint, as I told you, because the clinical relevance of ECB has not been identified or approved by CLSI. Earlier, that is in 2019 and all, colistin for Enterobacteriaceae in CLSA was classified uh, as ECOF breakpoint, but however, subsequently colistin for Enterobacteriaceae they have established a clinical breakpoint. So now colistin for Enterobacteriaceae is no more ECOF breakpoint available. Now ECOF breakpoint as per as CLSA 21 is concerned, the ECB or ECOF, see ECB and ECOF both are, the expansion of both are same. ECB means epidemiological cutoff value. ECOF also epidemiological cutoff value. Only thing is ECB is an abbreviation used by CLSI. ECOF is an abbreviation used by EUCAST. Otherwise, expansion of these abbreviations are same. That is epidemiological cutoff value. Okay, so according to CLSI, the ECB values are available in 2021 only for vancomycin against this many isolates. The not much examples are available. However, UCAS has a long list of example. Among this, the most widely used by clinician kind of example is phosphomycin for Pseudomonas species. In CLSI, there is no phosphomycin breakpoint at all for uh, Pseudomonas, whereas in UCAS, phosphomycin clinical breakpoints are not there for Pseudomonas, but at least ECOF breakpoints are available. So these are the detailed list. There are some more rare examples also which I did not include in the list. All these are UCAS, ECOF breakpoint. So you must be thinking how ECOF breakpoints are determined. So I will show you a flow chart which will clearly give you an insight of how the ECOF breakpoints are available. For example, CLSI, the phosphomycin Pseudomonas, same example we can take. CLSI, there is no breakpoint available at all, neither ECOF breakpoint nor clinical breakpoint. Let us assume that CLSI is going to develop some ECOF breakpoint for phosphomycin for Pseudomonas. So the first step is it will choose the lab. At least 3 labs you have to choose. Minimum you have to collect the isolates from 3 different labs, and all together at least 100 isolate you have to collect. Minimum 100 isolate you have to collect from 3 different lab, like at least in each lab 30 isolate, like that. So that all 3 lab together minimum 100 isolate you have to collect. And those 100 isolate, you should ask the lab to test for MIC, and they can give you what is the MIC for those 100 isolates. MIC is, that it is the lowest concentration which will inhibit the organism to grow. So please remember, there should not be any off scale value, like the lab should not tell that the MIC is less than equal to 1. The lab should do enough dilutions to say that the MIC is 0.25, or the MIC, they should not say that the MIC is more than equal to 8. They should do enough dilution to say that the MIC is 256.0. So the on scale value means the exact MIC value the lab should be able to inform you. Then what you do is you also ask the lab to detect any phenotypic resistant mechanism. You detect any resistant mechanisms are available for phosphomycin for Pseudomonas. So the lab also has to test the various resistant mechanism detection methods to see that whether any mechanism of resistance is available. If any mechanism of resistance is available, lab can denote those strains as non-wild type strain because a mechanism of resistance is detected. If you do not detect any mechanism of resistance, then such strains can be referred by the lab as wild type strain. After that, you have to collect the strains from the lab. At least, as I told you, at least 100 isolates has to be collected and data has to be merged. Then the next step is you have to calculate what is the ECOF breakpoint. You have to determine what is the ECV breakpoint that can reliably differentiate into wild type and non-wild type state. You can do it by 2 methods. The EGS method is, you can do it. The EGS method is, you can do it by visual inspection. Okay. What do you mean by ECB? ECB is the breakpoint which will differentiate into non-wild type and wild type strain. Suppose there are 100 strains. Out of the 100 strains, 70 strains are having no resistance of mechanism detected. Let's say 30 strains, there are some resistance of mechanism detected. So you can classify them into 2 groups, the strains into non-wild type strains and wild type strains. Let's say all the non-wild type strains, the MIC values are from 0.25 to, let's say, up to 8. 0.25 to 8. In these dilutions, all the 70 non-wild type strains are fitting into. Their MICs are falling into this dilutions only. Let's say those 30 wild types uh, strains. Let's say the 30 wild type strains, the MIC value is fitting into, let's say, 0.001 up to 0.12. Let's say 0.001 up to 0.12. So then what is the EUCAST breakpoint here? EUCAST breakpoint here is, it is the highest MIC of the organism which is devoid of any resistance mechanism. That is wild type strain ka highest wild type strain ka highest MIC. That is in this example, it will become 0.12. So 0.12 will become the ECOF breakpoint for this example. So what I told you is the EGS method of detection of ECB, determining the ECB breakpoint is go for visual inspection. If the wild type and non-wild type strains are clearly distinguishable from each other, then visual inspection itself is enough to determine the ECB. However, if there is no obvious if there is obvious overlap between the MIC values between the wild and non-wild type strain, like some wild type strain will have a higher MIC, some non-wild type strain will have lower MICs. If you have overlap, then you can use the statistical methods. There are some statistical methods are available by which ECOF breakpoints can be determined. Okay, then why to test?
So,
Yes.
sir, then, sir, even for susceptibility definition says the highest MIC at which the growth is.
Yes. So the difference is, this is only, you are only differentiating the strain into non-wild type and non-wild type strain, which determines that non-wild type strain do not have any resistance mechanisms, are not detected by the labs, whereas wild type strain there are some resistance mechanisms detected. However, PKPD parameters are not established. Neither the clinical outcome data also is available. PKPD parameter means the susceptible, PKPD parameter means whether the non-wild type strain is always going to achieve the same serum concentration and it is clinically effective. Clinical outcome data is whether it is clinically effective or not, whether it is going to inhibit the organism in vivo with inside the patient. So these two data, because it is not available, so initially you will place them into ECOF breakpoint. How in another 1 or 2 years later, if you have enough PKPD and clinical outcome data available,
Then establish the clinical.
the clinical, that is how colistin for enterobacteriaceae, now you have a clinical breakpoint, but earlier the clinical breakpoint was not there, only PKPD, only the ECOF breakpoint was available. Okay, then why to test for ECB breakpoint? Now you can ask us, sir, ECOF breakpoint is not useful clinically. So whether we have to look for ECB, whether we have to test for phosphomycin. Now Biomerio is coming with a new card for 405 Vitec card is now available. It has, sorry, 406 Vitec card is available, where phosphomycin is available in that card, and it is going to be tested against pseudomonas. So why to test? Is ECOF breakpoints are available? Why we have to test? Answer is, if physicians are interested to know about ECOF breakpoint, especially AMSP team, IED specialists, all this, if they want to know the ECOF breakpoint, because there is nothing is available, when nothing is available, at least the ECOF breakpoint I will apply and I will see what is the result. It is a wild type strain or it is a non-wild type strain. So lab can consider, if clinicians are interested, lab may consider in their patient report to include WT or NWT, that is wild type or non-wild type, with the MIC value what is been obtained, that can be added to the clinical report. This is a statement from CLSI. However, you should not manipulate the report saying that WT means R and WT means S. That is wrong. You should not do that. But you can consider mentioning that, so that at least the physicians, if alternate drugs are available, at least the physician may choose not to consider the NWT strains for the treatment. At least the not choosing a strain for not choosing the NWT result. If a drug is having NWT result, non-Weinstein breakpoint, then at least the clinician will not choose such phosphomycin to treat pseudomonas infection if you have other therapeutic options available. If no other therapeutic options available, then it is their choice to choose, but lab should not tell them that NWT is S and WT equal to R. That should not be done. Lab must refrain from reporting S and R result, as there is no clinical data available. EUCAST has got one more statement also. EUCAST says that ECOF do not predict clinical susceptibility, but in some situations where there is no other antibiotic are available for treatment, and when combination therapy you want to give, in such case you can consider ECOF non-wild type breakpoint if available. You can consider for treatment if there is no other option available, and if you want to give that antibiotic as a part of a combination regimen. So this is a statement from CLSI, sorry, UCAS. Okay, now there are two more concepts: equivalent agent concept, and the surrogate marker concept. So you have some MCQ. So can you show the MCQ, please, Neeraj? The
Yes,
poll
sir.
MCQ you can show.
So, yeah, yes, sir. We are doing. So, just to inform, we are running 1 hour late in our program, so we can.
Yeah. So we have two choices. Either we can go fast, or I mean, we have three choices. We can go fast, we can go in the same speed and extend our duration, or we can go in the same speed and leave some of the topics. So these are the three choices. We will see after some time how to go about.
Can I start the polling?
Yeah, I told you to start the polling. So how many questions? I think 5 questions are there, right?
Polling time is 2.5 minutes. Time
Yeah.
start now.
5 questions are there, so you have 2.5 minutes.
10 seconds left. Time is up. Time is up now. Link is closed right now.
Yeah, fine. So we will, you please display the result, please.
Yes, sir, I'm showing.
In the meanwhile, we'll start discussing. So according to CLSI, which of the following is considered as equivalent agent? Which of the following cannot be considered? So it's a negative question. So which of the following cannot be considered as equivalent agent? So as many of you answered, the first option is correct. So what do you mean by equivalent agent? You can close the answer, this poll. You can show this later. Close the result and show later when I will tell. Okay. So equivalent agent means what? Equivalent agent is the result of agent A can be extrapolated for agent B and vice versa. Result of agent A can be extrapolated for agent B and vice versa. Why? Because they show cross susceptibility and they show cross resistance. The very classical example is ceftriaxone and cefotaxime. These are the two antibiotics for Enterobacteriaceae family or for enterobacterials. They are considered as equivalent agent. If you test ceftriaxone, you can report cefotaxime. You can test cefotaxime, you can report ceftriaxone. Okay, so these are the CLSA list of equivalent agent. I have prepared a table out of this which is easy to understand. So these are CLSA list of equivalent agent. You can see cefotaxime and ceftriaxone for enterobacterial, colistin polymyxin B for enterobacterial, Pseudomonas and A. bomini, azithromycin, clarithromycin for staphylococcus, ampicillin, amoxicillin for Haemophilus. So these are the list of equivalent agent which you have to remember. So if you test one, you can report for others. So you here what you need to understand is you have to put a comment. You have to put a footnote in your AST result. Enterobacteriaceae, if you are reporting, if you are testing ceftriaxone, then below the AST table, one comment should appear that ceftriaxone result can be extrapolated for cefotaxime, so that the clinician will be aware. The clinician will not know that they are equivalent agent. You have to inform them in the report so that they will consider this point in the treatment. Okay. The next is surrogate marker. Can you display the answer? The this question also we have discussed. I mean, we have done the polling here. Tetracycline, doxycycline is not a surrogate marker. Rest all are surrogate marker. So 47% of you have answered it correct. So what do you mean by surrogate marker? That I will tell little later. First is why doxycycline and tetracycline are not surrogate marker for Acinetobacter. The reason is if tetracycline is a sensitive, you can consider as sensitive to doxycycline, but the vice versa is not correct. That is, if the tetracycline is reported as intermediate or resistant, then you cannot assume that it is the same result for doxy or mino. You have to test doxy or mino separately. So that is why they are not equivalent agent or they are not surrogate marker, because when you test when you report a sensitive for tetracycline, it can be extrapolated, but resistant or intermediate reports cannot be extrapolated. The remaining all in the list are example of surrogate marker. What do you mean by surrogate marker? Surrogate marker is agent A result can be extrapolated for agent B or a group of agent. However, the vice versa is not true. Whereas equivalent agent is A can be reported for B and the result of B can be extrapolated for A. This is the definition of equivalent agent. Whereas surrogate marker, agent A result can be extrapolated for B, but the vice versa is not correct. You cannot report the other way around. And usually, I repeat, usually what you are testing is only for testing, not for treatment. What you are reporting is usually given as a treatment to the patient. The classical example is oxacillin is a surrogate marker for all beta lactam for oxacillin is a surrogate marker for all beta lactam against Staphylococcus aureus. Okay, so oxacillin is not given for treatment. What is given for treatment is cloxacillin, dicloxacillin. And similarly, cefoxitin also is a surrogate marker for all beta lactam against Staphylococcus aureus. So in this case, two things you have to remember. Surrogate agent, there are two criteria. One is agent A can be extrapolated for agent B or a group of agent, but the other way around is not correct. So the same thing is applicable here also. Oxacillin result can be extrapolated for all beta lactam, but all beta lactam result is not extrapolating for oxacillin. And the second criteria is agent A is usually tested but not reported. What is reported in the patient group is group agent B, because this is what is going to be added to the antibiogram. Okay, so this is an exhaustive list of surrogate agent. We have tried to make it little simplified table for you. So I have already told you that cefoxitin is a surrogate marker for all beta lactam for Staphylococcus aureus. MRSA, especially MRSA, it is a surrogate marker. Cefazolin is a surrogate marker for oral cephalosporins against uncomplicated UTI if these three are the organisms. Similarly, oxacillin 1 microgram disc is a surrogate marker for pneumococcus when testing for penicillin. So please remember, if you oxacillin you test and penicillin you report. P-floxacin you test and you report for ciprofloxacin for salmonella. So these are the agent used for treatment, whereas these are the surrogate agent used for diagnostic. Okay, so apart from the concept of equivalent agent and surrogate agent, there are various other examples of predicting susceptibility, which is in CLSI it is not classified as surrogate or equivalent agent, but however it is mentioned in various places as predicting susceptibility. So this also you have to remember, and this you have to add as a footnote, as a comment to the clinician. Even in the previous slide also, the footnote should come when you report cefoxitin, and when you test cefoxitin, you are reporting as oxacillin as sensitive or oxacillin as resistant. So when you are reporting oxacillin sensitive, a footnote should come that all beta lactam, it can be, the result can be extrapolated and can be given for treatment. If you report oxacillin as resistant, a footnote will you have to add that it is a surrogate marker for all beta lactam. Therefore, avoid all beta lactam because it is a MRSA strain. So such footnotes should appear in your AST table. The next table, what I showed you, the other example of predicting susceptibility. Here also the respective footnote will appear. I will not go into the detail because it is just a table what you do recollect, what you do remember. So I'll tell you one simple example. If enterococcus is susceptible to penicillin, then it can also be predicted susceptibility to all these agents. So this can be a extra comment in your clinical report, so that the clinician also will know that the respective other agents also can be given for treatment. Next is site specific reporting of antimicrobial. So this is also important. There are certain antimicrobial which are not given, which do not penetrate the blood-brain barrier adequately, and therefore should not be reported for CSF isolate. So please remember that carbapenems are not having good blood-brain barrier penetration except meropenem. Meropenem should be reported for CSF. Meropenem can be reported for CSF because it can penetrate, whereas imipenem, doripenem, ertapenem, other carbapenem, 2021 CLSI, they have added that you should not report for CSF isolate, and these are the other agent which should not be reported for CSF isolate. The detail is there in the next slide. So remember that the clindamycin, macrolide, tetracycline, quinolones, first, second generation cephalosporin, and any oral agents. All these are the agents which should be refrained from reporting on CSF isolate, and you can inform to your clinicians if they do not know that they should avoid this antibiotic when treating meningitis patients. Similarly, these are the antibiotic list which should be avoided for urinary tract. They do not achieve urinary concentrations. Therefore, you should avoid for urinary tract isolates. And daptomycin is a classical example which should not be reported on respiratory isolate. Okay, it will be inhibited by pulmonary surfactants. Therefore, it should be refrained for refraining. It should be refrained for reporting from respiratory isolate. It should not be given for pneumonia cases. Okay, so this is the CSF, the same list what I have shown you in those three questions are been given in a tabulated format. So this is all about the session. We have now completed the general terminology. We have taken almost the double time what we are supposed to take. I could not go fast. The reason is this is the basic uh, concepts. If you do not develop the concepts now, then the subsequent sessions it will be difficult. The next two sessions are again going to be very, very important sessions. The gram negatives we will be discussing first, followed by gram positive. So you can prepare from yourself that the sessions are going to be a little longer from now on. I mean, 8 o'clock we may not finish. We may go a little beyond that. Maybe up to 9 o'clock we may go. So you have to prepare yourself. You have to